Last thing we're going to talk about in chapter 5 is malaria. And there isn't a whole lot talked about in the text as far as malaria. There's a paragraph on page 87. And then on page 89, we have some drugs for both treatment and prevention of malaria. So it's not covered very thoroughly in the book, but they do say some things. And I would mention that World Malaria Day is coming up April 25th. Here is a little picture of the malaria life cycle, and I know you can't see it really well, but the mosquito bites the person, introduces the eggs of the protozoa. They go through certain division, they get in the bloodstream, and eventually they get in the liver. And once a person is infected with malaria, there's going to be the protozoa stays in the system, and it comes up and gives symptoms from time to time and is suppressed in others. Malaria is a huge problem in the rest of the world. Once again, here in the U.S. and in other areas of the Western world, we do not have this problem because our lakes and rivers are treated, our drinking water's treated. We don't have the problem that other areas have. But between 200 and 500 million people all over the world will get the disease every year, and between 2 and 3 million people die from it. I have a video that I'm going to attach a link to later that's, oh boy, it's rough to watch, about how malaria affects children. Malaria is caused by 4 species of one of the protozoa out there called Plasmodium, and there are 4 strains, some more resistant to drugs than others. It's transmitted to humans by the Anopheles mosquito, and only the female transmits it because male Anopheles mosquitoes eat nectar from flowers and all kinds of nice stuff, whereas the female is going to get you because she needs blood to feed her eggs. And so that's how it's transmitted. So what we have are drugs that interfere with the life cycle of whatever strain of Plasmodium that person has. And so these drugs can be used both for prophylaxis and for treatment of an existing case. Adverse reactions to these drugs vary. They, again, are very drug specific, and a lot of education is required when a person is put on either prophylaxis or treatment for malaria. Usually these folks have to kind of form a relationship with an infectious disease doctor and kind of keep up with them. I had a student about 5 years ago, and she was raised in Haiti. She was a missionary's daughter, and her entire family had been infected with malaria at one time or another, and they would still have periodic outbreaks of symptoms, and so from time to time she'd have to get back on her medication. And she shared with the class, it was very interesting, she talked about her family's experience with malaria and what they dealt with. But her whole family kind of regularly go to an infectious disease doctor when they need it, and they just kind of keep up with the malaria. And they only have outbreaks every few years, but she still has to kind of keep in touch with an infectious disease doctor. Many of these medications can cause abnormalities in the blood with red blood cells, platelets, white blood cells, and some of them can cause visual and neurologic changes. One of the drugs for treatment of malaria is a drug called chloroquine, trade name Aralen. Chloroquine and hydroxychloroquine are 2 drugs that are sometimes given. And both of these can affect the eyes. They can affect the retina, and they can affect the cornea. So people on these drugs have to see an ophthalmologist and be followed, as well as just the regular infectious disease doctor. These drugs can cause interactions with other drugs, and they, depending on the drug, they'll cause specific problems with the skin, the ears, or the central nervous system. But since malaria is very highly fatal, most of the time the benefit outweighs the risk. We need to recognize the symptoms of malaria should we end up working for an infectious disease doctor and come into contact with patients who have malaria. Of course, nursing diagnoses would be education, safety, how the meds affect the different organ systems. Planning, we want to let them know that the treatment is strain related, depending on what type of Plasmodium they have. That is what kind of meds they're going to be taking. If you remember, back when we covered Chapter 8, we talked about quinine poisoning. Some of our cardiac meds were derivatives of quinine or chemically related to quinine. And we talked about synchronism, which is quinine toxicity. Chloroquine, primaquine, and hydroxychloroquine can sometimes cause synchronism. And I don't know if you remember what the first side effect is, or the first sign of that is. Anybody remember? Going once, going twice? Tinnitus. Your ears start ringing. So we want to warn our patients to watch out for that. With starting out on treatment, the patient will usually get a loading dose, and then they'll be put on a regular maintenance dose. For prevention, in somebody going to a malaria endemic area, maybe they're taking a mission trip, maybe they're going for business, generally speaking, they will start on doxycycline, one of our tetracycline drugs. Remember the picture with the dachshund? Doxycycline will be started 2 weeks before someone travels to an area where malaria is common, and it will continue for 8 weeks after as a preventative. So what we need to tell our patients is to keep in contact with their healthcare provider. They want to continue with lab testing, diagnostic monitoring, chloroquine, eye examinations, because permanent retinal damage can be the result. All right, I believe that is it for Chapter 5. So watch these videos, take notes on your PowerPoint, and of course you'll be getting links and assignments that you can do in the future.